Hi, everybody. Welcome. We're excited to have you guys. So I am Natasha Emerson, and I am an pediatric psychologist by training, but in CF, I get the fortunate privilege of working with adults. I'm based out of UCLA, as is Dr. Turner, who's on the end of this table, who'll get a chance to introduce himself. But what we'll do is we'll introduce ourselves briefly and then kick off the talk. So I will hand it over to my co-chair, Katie.
Hi, everyone. Thank you for coming. My name is Katie Papia, formerly Henthorn. I am a licensed clinical social worker out of Long Island Jewish Adult CF Center in New York, and I really have a passion for advanced lung disease, lung transplant, and palliative care, along with mental health. So I'm really excited to have our speakers today and some patient and caregiver videos. So.
Good afternoon. My name is Cassandra Reedy. I am the CF mental health therapist at Inova Fairfax, and my role has also been expanded to support the wider thoracic transplant program.
Hi, good afternoon. I'm Kathy Moffat. I am a pediatric infectious disease specialist, former pediatric center director, now assistant, and I am a ethicist and a palliative care supporter sort of provider as well.
Hi, everyone. My name is Grant Turner. I'm an adult cystic fibrosis and transplant pulmonologist at UCLA and the associate director of our program.
Right.
Okay, well, so we're really excited to have you. Today we'll be talking about lung transplant, and the idea for this talk was to have a variety of perspectives. So you'll hear, we'll start it off with some really wonderful patient videos, but the idea was to also have speakers and providers that are from different areas of the lung transplant healthcare team. And so hopefully it'll give you a good understanding of where we stand with lung transplant as it deals with CF. So neither Katie nor I have any disclosures, and we've basically briefly introduced ourselves. So I think that I'll kick it off to our presentations, and this is basically the order of the slides, the presentations that we'll have. So we will first start with a patient and a caregiver video, and that will be the only portion that doesn't have a live Q&A, and then we'll have our three wonderful speakers.
Awesome. Let me pull them up.
Hello, everyone. I'm so happy to be here with you today as I share a little about my life with CF and my transplant journey. I was born in 1981 in a small rural hospital situated on the border of Vermont and New Hampshire. There was pretty immediate concern as I would not eat or pass stool, two things healthy babies are definitely most known for. An astute doctor had suspicions and suggested I be transferred to Dartmouth-Hitchcock Medical Center for further testing. My parents, first-time parents, learned they had a baby with a disease they had never heard of and knew nothing about. Within days, I had an ileostomy, and my parents were learning how to change colostomy bags, in addition to learning all of the things parents are faced with. It's hard for most of us to remember a time before the internet, but in 1981, my parents learned about CF through medical professionals, brochures and pamphlets and library books. There were no Google searches, no WebMD, no online support groups. They were diligent with good old-fashioned chest PT, using one or two fingers at first, gradually advancing to full-palmed clapping as I grew. They did everything the doctor said, and then some. My dad made a part-time job out of calling and writing letters to our health insurance, fighting any denied claims, never taking no for an answer, oftentimes getting letters from doctors for backup. I tell you this to give you an idea of the type of parents I was blessed to be born to. Even with parents as loving and committed as mine, the CF journey is tough, to say the least, and the transplant journey daunting. But I have known other patients, not as lucky as me, who journeyed along a very different path. Outcomes to this genetic disease, as you know, can be so different, oftentimes heavily impacted by things we cannot control, like the start we receive in life. Life as a kid had been pretty normal, with enzymes, routine breathing treatments, and chest PT, and just being a kid. I was not hospitalized for my first tune-up until the age of 5. After that, hospitalizations once every couple of years became part of my normal. In my teens, IV treatments at home, coordinated and supervised by home healthcare companies, became more common, allowing me even more freedom and opportunities to normalize CF with my friends. When I was 19 years old and in college, the final piece of the puzzle, my first therapy vest, solidified the independence of my care. After college, I even moved cross-country to begin my career. It was not until my mid-20s that CF began demanding more and more of my attention. During that time, I lost a lot of weight in a short period and was quickly diagnosed with CF-related diabetes. I remember being in my local CVS and just breaking down in the diabetic supply aisle, not knowing how I could also manage this new aspect of my care. At the age of 29, after more frequent infections and declining lung function, my center brought up lung transplant to me for the first time. My doctor at the time estimated I would need a transplant within 5 to 7 years. This would become an incredibly accurate estimate. Less than 1 year later, I moved back to New York to be with my family and my biggest support system. My first appointment at Columbia University Medical Center was in 2013. At the time, I was too healthy to begin much of the transplant process, but began establishing a relationship with the team with visits every 6 months. As my lungs continued their slow decline, I began using supplemental oxygen. I was slowly accepting this new version of my normal when, like a bolt from the blue, I was diagnosed with chronic myeloid leukemia in the spring of 2015, after routine lab work showed an outrageously high white cell count. My transplant journey had to be suspended based on this malignancy, as protocol at the time was the need to be in remission for 5 years before being listed. However, the silver lining in this devastating diagnosis was that there had been an oral chemo that had shown great success in causing major molecular remission in CML patients. I reached this goal of major molecular remission in less than a year, and with my amazing transplant pulmonologist and team betting on this continued success, I was officially listed for transplant in August of 2017. The team has since published an article on my journey in the hopes that other centers would look to my success and take a chance on another patient in my situation. So with all of this happening, how was I holding up? The answer, I was doing my best, but it was really starting to take its toll on my mental health. As I got further along for my wait for transplant, my teeth would begin to chatter when my cell phone would ring, sometimes progressing into full body shakes. Even if the call was for something as simple as rescheduling an appointment, my body would turn cold and the chattering would begin, oftentimes impairing my speech. In all honesty, that can still happen now, but to a much lesser degree. My main coping mechanism at the time was that I learned to live 5 minutes at a time. 5 minutes at a time with not just my physical movements, but with my thoughts and emotions as well. I routinely saw a therapist pre-transplant for several years. At times it was incredibly hard, but it did help. For the state I was in at the time, I couldn't even tell you how my mind processed things. It just did. and my therapist guided me through it in a gentle, understanding way. I was encouraged by my transplant team to focus on things I wanted to do after my transplant. I focused on being able to walk my dog, Moki, my best friend that had been in my life for 11 years up until that point. My family credits him on how I stayed strong for so long. I lived for him in a way. I cared for him and his needs, and in return, he gave me unconditional love and companionship. I'm so grateful that he lived long enough to see me through my transplant journey and enjoy many long walks together again. He also saw me in a happy, loving relationship with my long-term boyfriend, David, before he left us. Now, I walk our 3-year-old Black Lab mix, Odin, every day. After being listed in August of 2017, it was 15 months and 4 dry runs later that I got the call. And on November 14th, 2018, I received 2 new lungs. Despite a few setbacks, none of them lung related, I am living a life that amazes me every day. Now, from the outside, I appear happy, grateful, and positive, and I am all of those things. But I also struggle with anxiety on a regular basis. Sometimes things feel too good, and that scares me. If things are this good, what am I missing? I will often stop what I am doing and do a sort of mental full body scan to see if there is something I should be addressing, treating, or alerting my team to. It can be very hard to relax into my content. It goes without saying that I never miss a routine cancer screening, dermatology, gastroenterology, gynecology, hematology. Yes, my appointment book is very full. I do also have a prescription for medication for my anxiety when things feel too overwhelming. I was asked to include thoughts here today on things that would be important for providers new to CF and transplant to know from a patient and family perspective. One of them being the responsibility we often have to take in addition to the care and maintenance of our disease. Pre-transplant, while doing what was required just to make it through the day, I was also making calls to ask for a second or third time to have test or lab results sent to my transplant center, correcting fax numbers, calling my insurance to see why a prior auth was not approved. These things that I knew had to be done, but I was running out of the energy to do. I really could have used the energy spent during those times in other ways. My family helped when they could, but it was oftentimes something I needed to do. I know that CF centers and transplant centers have been working very hard on the logistics of pre-transplant coordination, and I simply encourage you to keep up that important work. I recently asked my mom, my primary caregiver throughout the entire transplant experience, what stood out to her as something that could have made the transplant experience a little easier on the family. Only one thing came to mind. She reminded me of a meeting we had with a member of the medical team that told my parents that by having a transplant, I was trading one disease for another. This particular incident I had forgotten, but the sentiment I had not. When she recounted this to me, the emotion was as raw as ever, nearly 7 years later. She told me that parents, in the midst of going through everything they could do to save their child's life, should not hear transplant distilled into such a short, rather glib headline. It is, of course, important to make sure that everyone knows all of the risks of transplant. But that is a larger conversation that deserves the appropriate time in every setting. Language between healthcare workers can be distilled, definitely. Language between medical professionals and patients and families is quite a different thing. Thanks to all of you for your work to continually improve not only outcomes, but the patient experience as well. Thank you for hearing my story here today.
Okay. And Kelly's email is here, and she said if anyone has any questions for her, that she'd be more than willing to take them. Oh, yep, sorry.
Hello, everyone. My name is.
I will. And while we're doing that, you want to just grab it? I wanted to give a plug. If you click on my name in this session on the NACFC app, there is, in the handout section, there's a recently published article in Respiratory Medicine, a scoping review of mental health and transplantation in CF. That's really wonderful if you want to take a look at it. It's definitely worth a read.
Hello, everyone. My name is Leah Morgan, and I am very excited to be speaking to you today about the life of a CF caregiver through lung transplant. So, who am I and why am I here? So, I am here as a caregiver to someone named Tabor. My caregiving journey has taken a couple of different routes. So, first I was a girlfriend. Then I was a spouse to someone with a chronic illness, and now that Tabor and I are no longer together, I am a friend to Tabor and still very much part of the caregiving team, but just in a very different way. But I also have listed a couple of other roles I wear and other hats I wear, because I think it's important to understand the lens of what I bring to my caregiving journey and who I am as a person. So I am a pediatric nurse. At the time, I was a PhD student, but now I'm a professor of nursing and I'm a researcher. So these are all kind of things that you might see play a role in who I am. So since this is about transplants, I want to try to skip through this as much as possible and give you an overview that I met Tabor when he called himself high functioning sick. So he had low to mid 20s in his PFTs, for about 10 years by the time I met him, but he was relatively stable. I always joke, like, well, he wasn't running marathons, but, he was doing well. But I also wasn't running marathons, so, we were doing okay. But really, the real beginning of this story is in 2018. So the summer of 2018, when Tabor was still pretty healthy and relatively stable, his cystic fibrosis team sat down and decided to have a big meeting preemptively to plan for the next stages of illness. They had all the right people at the table. They invited his whole family, and they laid out the roads that we might want to take. So whether it be palliative care or transplant, and they told us all of the pros and cons of both paths, and it was really amazing. But this was also really exciting news for Tabor and his family at the time, because they had been told for many years that he was ineligible for a transplant due to a bacteria he was growing that he no longer was growing. So he was excited about the opportunity of even having the opportunity to have a transplant, right? And he very quickly, after hearing all of the paths and the pros and the cons that they rightfully laid out, he very quickly made the decision he would want to go for a transplant if and when the time came. So we met with Transplant that summer at our hospital, and they wanted to just be quote unquote on the radar, but they told us after doing their test and reviewing all the labs that he might be a couple of years out from transplant, and that was very exciting to us. So we went on living our lives. And very shortly after, in the fall of 2018, both Tabor and I came down with a nasty viral respiratory illness. And in a few weeks, when we came out of the fog that was the illness, I got better and Tabor just did not. So going to check in with the doctors, they could see it left him with a lot of inflammation in his lungs, and it had taken a good hit to his lung function. And at that time, he was put on full-time oxygen, which he had never been on, or not in a very long time. And this, as a caregiver, oxygen brought a whole new level of responsibility to our home and to our lives that I was not aware of. So in December of that year, it was actually Tabor and I who said, hey, I think we need to check back in with Transplant. Like, he's doing a lot worse, right? And so we went in and they ran their tests and they did their labs, and they very frankly said that he needed to be on the transplant list immediately. So remember, just 4 or 5 months earlier, we were told a couple of years, and then all of a sudden, this needs to happen as soon as possible. So I'm glad we had the conversation early, but I can tell you it didn't change the overwhelming panic we felt when we were told that you need lungs immediately in order to live. The next 2 months were busy with appointments, labs, tests, daily classes, daily physical therapy, and, we had to move. So people often ask how I survived this while going to school and, being a nurse, and the answer is we had no other choice. We were busy enough with the required activities that the mind didn't have too much time to ruminate and worry about what was going on. But I can tell you, the anxiety was there. So when I was asked to talk about the caregiving journey around transplant, I think a lot of people think of the after transplant. So our team warned me about all of the things after transplant. I would need to be out of work for 3 months, but no one really told me about how much work this pre-transplant was going to be. So I would say for me, 90% of my caregiving, physical caregiving, came in this time. We were having to juggle appointments, carrying the oxygen tanks all the way. We were balancing his treatments, both lung treatments, IV meds, medications, with all the classes he was required to take, I was required to take. Tabor needed help with every aspect of his daily living at this point because of his decreased lung function. His PFTs, his FEV1 was down to about 12%. And we had a million plates to keep spinning. So I had to take a leave from school early and work to do all of these things, the pre-transplant things that no one warned me about. And it just all happened so fast. And just as fast as the conversation about transplant came up, so too did the actual lung transplant. After completing the 1,000,001 things required, Tabor was listed for a bilateral lung transplant on February 14th of 2019 and received the call on February 21st, 2019 that they had us a new pair of lungs. The day itself was really joyful, despite my tears. We were lucky enough to have friends and family around us, and I felt a sense of ease that day, that the waiting was over. I know we only waited a week, but the waiting was over, and that whatever was going to happen that day, and we were going to feel peace about that. The recovery in the hospital brought its ups and downs, as any hospital journey does, but I like to show these pictures both symbolically and physically to represent his recovery in the hospital. So the first day, he had a lot of team members helping him walk, helping with all of his all of the things he had attached to him. Within the first week, it was just him and I walking up and down the halls with just his IV pole, his walker, and some chest tubes. And a couple days later, all of those things had been pulled, and it was just Tabor walking by himself with his telemetry box. Before we went to the hospital, Tabor could not walk from the bed to the bathroom without my assistance. And within the hospital, he was walking 2 miles by himself in one go-round. So he really had a physical recovery that was amazing, even after leaving the hospital. These pictures show just how small and pale he was. Those pictures down there on the right, that pale one was him the day he got listed for a transplant. And you can see the color and the weight and the liveliness in his face just grow within just a couple of weeks and a couple of months. But since this is talking about caregiving, I'll try to keep it to just my role and not all of his recovery journey. But truly, when he left the hospital, he didn't need my formal caregiving. He didn't need help walking around or getting out of bed or anything. So I know where a lot of people have a lot of transplant needs, physical needs after transplant. That was just not the case for us. We were really lucky. He really walked out with a completely different physical body. Notice I say physical because Tabor still needed a lot of help with remembering to do his medical tasks. Throughout our relationship, I had to remind him constantly to complete his treatments, take his medicines, check his blood sugar, all of those things. And though the reminders of what needed to happen after transplant changed, my role in heckling him, yes, heckling, him never changed. And this is why it's important to know I'm a nurse. Because the huge struggle of my caregiving journey and the huge struggle of Tabor and I's personal relationship revolves around his inability to take responsibility for his own medical treatment and my inability to let him have control of his medical treatment. As a nurse and a very type A person, for every minute he wasn't taking his meds after they were due, I'm thinking of all of the things of how the body is starting to fight. And for him, it's no big deal. But for me, every minute after, my anxiety was creeping in and creeping in, creeping in. And then I had this contention of, do I remind him to take the med and where I'm kind of bothering him and pestering him? Or do I let him not take the med and then he's not taking his meds and then he's rejecting his lungs? So as you can see, it was distressing to me then, and I would be lying if I said it wasn't still distressing to me now. Even as we're no longer romantically together, I still worry. And I've had to take a step back. And I remind myself what the wonderful transplant team has tried to tell me for years, which is that his well-being is only his, and I cannot be responsible for his well-being alone. But man, is that hard. So just to jump ahead in time, Tabor's transplant allowed him and I to do things we never dreamed of. We got engaged, we got married, we had a house, he got a job for the first time. So one piece of Tabor's mental framework is that he never expected to live past the time he was a teenager, and he never planned for a future. He never planned any of this. So all of these activities, as exciting as they were still very overwhelming to Tabor. And in the fall of 2023, Tabor fell into a deep depression that he is still not fully out of 2 years later. He struggles to balance wanting to be alive and questioning why he was chosen to survive. He feels the weight of living for another human being because he knows personally that someone died for him to survive. So this means even on any day, if he isn't feeling his happiness or he didn't do something the best, he feels shame that he isn't living the life to the fullest. He also never planned to make it this far, so he had no idea what he wants to do with his life, career or otherwise. And this is really overwhelming. So as a caregiver and as a wife at the time, it was so much easier for me to keep telling him to do his medications, but when it comes to his mental health, there's not a clear answer. And he is struggling, his team is struggling, and I am struggling to figure out how to bring back the spark to his eyes. So I don't have a fairy tale ending or even an end because it's still ongoing, but I can tell you that things are looking up and we are doing okay. So I was asked to bring forth some recommendations from my perspective for a cystic fibrosis team or a transplant team. And though I have a lot of nuanced thoughts that I'd be happy to talk more about, here's what I came up with. 1, be firm in your recommendations for therapy, both pre and post-transplant. If someone had done a deep dive into Tabor's life, they could have seen that all of the red flags were there and he was going to struggle to be happy. But in the moment they met him, he was in a good place, so they didn't see it, but they can't see. But depression runs really deep in Tabor's life. He has real trauma from his childhood that he has never dealt with. And his feelings of inadequacy are not new, and I wish that we would have taken care of them earlier. So please screen for trauma before your transplant, and it's going to help you and make better recommendations for their mental health. 2 is obviously utilize your caregivers. So Tabor's team has been wonderful in really bringing him and I as members of the team. I feel a part of the team even now. And really, I am the translator between Tabor and the medical team, whether that's good or bad. I speak the language of Tabor and I bring it back to the team, or they tell me things and I take it and tell it to Tabor. And I think that's been really helpful. And so utilize your caregivers for the strengths they have. Maybe they have different strengths than I do, but they are part of the team. So make sure they feel part of the team. Then I just wish there had been a post-transplant caregiver support, because my team, the group that we kind of went with through the transplant journey, was a lot of older adults that didn't have cystic fibrosis with their wives, so they were lovely, or cystic fibrosis patients with their parents. But I haven't still gotten to talk to someone who loves someone with cystic fibrosis and who went through this. So I think that's really an interesting niche of a group. And of course, we can't go through any of this without thanking Brittany, his wonderful lung donor. And we were lucky enough to meet her dad there on the right, through meeting through the donors associations and writing letters and talking on the phone. Him and his wife were able to come to Tabor and I's wedding. And of course, the classic picture of him listening to his daughter's lungs in a new body. And none of this would have been possible without her or her family. So I can't go a day without thanking her. But I also want to thank you for allowing me to speak today. Thank you.
Always gets me.
Yeah, Katie warned me that I was going to cry. Yes.
Sorry. And if anyone wants to touch base with Leah, I thought she was phenomenal. I have her email, so you can come see me after, or you can email me and I can give it to you. She wants to be more involved in the transplant and CF community, so. Okay.
Good afternoon. When I first was given the honor of being part of this panel, I jumped right in and thought, oh, I'm going to talk about intersectionality. I'm going to talk about trauma and how traumas overlap and how folks who have been through previous traumas, such as because of their race, because of adverse childhood experiences, because of their sexual orientation, that can make it harder to face the traumas that they experienced during the transplant process. So I got all excited to jump in the weeds of that and talk about equity and healthcare. And then I met with this wonderful panel who helped me realize that I needed to take a step back and explain what I do. Because not every CF clinic and not every transplant program has a mental health therapist dedicated on staff that patients can spend time with. So I'm going to share with y'all what I do in hopes that more clinics and more transplant programs think about bringing a mental health therapist on staff. So as we said, my name's Cassandra Reedy. I'm a licensed marriage and family therapist. That means I use a systems perspective a lot of the time, and you'll see I actually do couples and family therapy with patients. As Leah was pointing out, caregivers really matter. I do not have any relationships to disclose. So a bit about my history and how I came to this position. My wonderful team brought me on using the funds from the Foundation for a Mental Health Coordinator. We knew I had 16 hours a week, and we really didn't know what it was going to look like except for me sharing time with patients. And my team was awesome and trusting enough to let me figure out what that was going to look like. And it's been a really fun journey in figuring out what our patients' needs are inductively and how to address those needs. So as a CF therapist, because I find patients don't prefer talking about a mental health therapist, CF therapist goes over a little bit better. I do weekly therapy with patients. Most of my patients I've been seeing for about 2 years now, since when I started. They're very loyal. They keep coming back. I'm really grateful for that. I also do psychoeducation. So a really great example is if one of our patients gets pregnant, they'll say, why don't you talk to Cassie? And I can just provide information about pregnancy, about body changes, about all different sorts of the perinatal experience. And then patients choose whether they want to keep going with therapy or whether just having that information helps normalize things for them. Probably the most fun thing I do, I get really excited for this every week. I actually started a Dungeons and Dragons group with our patients because most of them haven't met someone else with CF. And so we have a really fun time each week playing Dungeons and Dragons. And sometimes they get suspicious that I'm doing some therapy while we're playing, but I try not to. I try to just focus on the ogres. And then I think sometimes I help with team dynamics too. Recently we had a retreat, and it's really fun to figure out how we get all these wonderful people with the same goal, but different lenses working together. And so I really loved what I did, and I said to the team, I want to do more, please. And they were kind enough to go to ANOVA and say, how do we help her do more? And that's when I became a thoracic transplant therapist as well. So now I support the wider thoracic transplant program. And so I work with bilateral lung transplants, and I work with heart transplant patients as well. And so what that looks like, I do pre-bolt therapy. So folks who are getting ready to be listed or have been listed. I do post-bolt therapy. Sometimes it's people I've seen pre and we work all the way through. That's really awesome. Sometimes it's folks just afterwards. I do couples and family therapy. I also advocate for patients on committee, something I never thought I would ever do, be part of life and death decisions like that. And I am in the process of forming support groups with some of the social workers on the team to help patients. I'll get into the details of this a bit more later. So Leah mentioned the word trauma. Kelly was talking about her trauma symptoms. Every single patient that I've worked with post-transplant across the board presents with trauma symptoms. Those can be very physical, like we heard Kelly talking about her teeth chattering when the phone rings from the hospital, or patients whose heart starts to race as soon as they smell the hospital smell. It can be emotional. Kelly was also talking about that anxiety that sits with her that something bad's going to happen, right? A lot of our patients talk about just feeling like something's going to go wrong, right? It can also be cognitive as well, whether it's cognitive patterns like catastrophizing, thinking about the worst case scenario or not being able to turn their thoughts off, or it can be specific thoughts. We heard Leah talking about really hard thoughts a lot of our patients face, like, am I worthy of these lungs that I got? And those are really hard thoughts to carry around each day. So trauma, in very, very short summary, impacts our understanding of ourself and our identity. Trauma also impacts our understanding of relationships and how we can be present to people in our relationships. It also impacts our understanding of the world and its systems. Is the world a safe place or is it not, right? Trauma begs a lot of questions of, am I safe? And traumatized persons need choice. They need a sense of agency. They need trust, and they need hope. So I'm going to explain a little bit about how I try and work with folks to create choice, trust, and hope in their life. All therapists operate from a theoretical orientation. It helps ground us. The one that I use with transplant patients isn't the one that I started with, and I'm going to give you a case study about how I came to use this theory as the map when I work with bilateral lung transplant patients. There's a book called The Wounded Storyteller by a sociologist named Arthur Frank. He interviewed many, many people with terminal and chronic illness. And when he interviewed them, he noticed that as they told their story, they had a particular structure for their story. And he noticed 3 structures that stood out across the board. And so when I work with patients, I'm listening not for the contents of their story alone, but for the way they're telling their story too. And so one of those narrative structures is the restitution narrative. And I'll be real direct, that's the one we like in medicine. That's the one that says there's a cure, there's this normal, and we can get back to that normal, right? It says that there's something that we can fix and we can find our way back. Then there's the chaos narrative. This one's the hardest for folks to live with, and it's the hardest to hear and sit with, because this narrative says there really is no order. So if you hear a chaos narrative, you hear a lot of and then, and there's not the anticipation that there's a rhyme or reason. It's more like life is happening to you. And then there's a quest narrative. And Arthur Frank said he saw the most wellness and healing in the folks who were speaking through a quest narrative, which is the idea is that things have happened to me, like a diagnosis or living with chronic or terminal illness. And it's up to me to figure out what my quest is to make meaning of this for my life, accepting that it's going to be the reality and that a new meaning needs to match what has happened rather than trying to go back to the old way of seeing things or the old meaning. So about 2 weeks into my role, maybe 1 week, I got an email from one of our pulmonologists saying, can you please help this gentleman? He's had a bilateral lung transplant. He's telling me that he can smell the hospital on him all the time. He's telling me that he's not sleeping well at night. He was having a really tough time. And so I said, of course, and this was my first ever bilateral lung transplant patient. I've been working with him for almost 2 years now. When I first started working with him, it was very clear that his hope was to live into a restitution narrative. This gentleman wanted his life to go back to the normal he had before transplant. And this desire to get his life, back there created an immense amount of pressure because there was the reality he was living and the reality he wanted to live, and this trying to force the two together. And it became very clear to me right away that as someone who had previously been in the more structured or routinized way of doing therapy of you meet once a week for 50 minutes. I was, nope, this isn't going to work. We need to get this pressure down, and I can't do it in 50 minutes a week. So I started meeting with this gentleman twice a week, sometimes 3 times a week. And we did that until the pressure came down. And that was the first step, was just get this pressure down so that you're no longer in crisis. And the way that we did that was helping him to accept the fact that life wasn't going to go back to the way it was. And I include some quotes and insights to help illustrate this. He said, I feel all this pressure to be grateful, right? This is the way people want me to show up. And I feel this pressure to smile and show up this way, like everything's okay. He talked about the lists of things he can't do. He can't eat mayonnaise. He can't have ice at restaurants, right? All of these things. He can't travel and see family members that are outside of a certain radius, right? These things, he really loves sushi. Really loves sushi. And that one is just not going to happen. And that really stinks. He talked about his desire not to be a burden, to go back to the relationships he had with the loved ones in his life, to no longer have to rely on his husband the same way that he did post-transplant, to be able to show up for his son the same way he did before transplant. And that's what I said in the next bullet, wanting to return to his roles. This gentleman's also an extremely accomplished professional, and he was missing that. He really wanted to go back to just being able to work on a project and just do his thing because he's good at it. He was struggling to look at his scar, and he was struggling with his weight. This is a gentleman who took very good care of his body, always looked muscular and enjoyed that. And he would look in the mirror and not recognize himself, and he just wanted his body back to the way it was. And he said he had this desire to mask, and what that meant was to go back to the person he used to be able to walk in a room and laugh and joke the way he used to. And he said, ironically, now that I have to wear a mask when I go in a room, I can't mask anymore because I'm wearing this patient identity on me all the time. And everyone will ask, are you contagious? What do you have? What's going on here? And so he can't help but be a post-lung transplant patient everywhere he goes. And so there was a lot of pressure and tension in this tug of war with the identity changes. Fortunately, we worked on this for a while. And actually, I thought this would be a helpful quote from the Wounded Storyteller. It says, the destination map I had used to navigate before were no longer useful. So I think that's really illustrative of the restitution narrative and why it doesn't work. Then came the chaos narrative, because we realized life wasn't going to go back to the way it was. And he was starting to look around and realize what life post-transplant is like. That you can go in for a bronch feeling okay and come out realizing that you're in rejection, right? Or that, next thing you know, you're trying to walk up the stairs and it's not happening. And so he really started to experience a loss of trust in himself and his body because he couldn't tell when he was sick or not, like the way he could pre-transplant. And a loss of trust in the transplant journey overall because it felt so chaotic going up and down, rejection, not rejection, this antibiotic, oh, now I have too many antibodies. He lost trust. And so he started feeling more activated again. And that's when we really started to see the intersecting traumas and the trauma symptoms start ramping up, because things had settled down enough for him to realize that he had felt really triggered by certain trauma symptoms that aligned with having adverse childhood experiences, having experienced racism throughout his whole life, and previous medical traumas from being a CF patient, from other diagnoses that he carries. And what I noticed in therapy is he started repeating his trauma narratives. So week after week, I'd hear about his childhood. Week after week, I'd hear about things he had gone through, right? And it was always, like I said, the structure was, and then this, and then this, and there wasn't an anchor. And so each day, therapy would be like its own distinctive hour because it wasn't following a trend or a storyline. It was just chaos for this gentleman. And like I said, he hadn't normalized what it was like to constantly be in rejection, out of rejection, constantly be having blood work and tests done. And he was struggling with the fact that he looked fine, but couldn't tell. And he had this liminal identity and sense of meaning. He hadn't quite figured out yet who he was going to be post-transplant. And a lot of it was because he felt like life was happening to him and he couldn't get out above it. Fortunately, we kept working together, and this gentleman started finding hope slowly but surely. I saw a decrease in baseline activation. I heard less and less about symptoms of him being triggered. He did adjust to a new normal that when in the beginning it was the R word, it wasn't rejection. We couldn't say rejection. Now we say the word all the time. That's part of his new normal, right? He started recognizing his ability to adapt. This gentleman is really naturally adaptive. He is sharp, he's smart. He knows now, he trusts that things may not go his way, but he can adapt to what's going on, right? No, I don't prefer to be inpatient next week, but I can do it and I can still FaceTime my children, right? I can still find ways to show up in their lives. He's starting to realize that he really has a sense of community in our clinic. He is beloved and he loves us. And I don't think that's an understatement. And he knows, he has said, you guys are there for me for better or for worse. It's like a marriage. But he's started recognizing that he has people who have his back, right? No, he doesn't want to be inpatient again, but they're familiar faces who care about him. And he was starting to bring stories of his identity back that connect to today. So I worked with this gentleman for 1.5 years, and all of a sudden I find out about these really awesome things that he's done in his past, right? Oh, I worked here and I totally redid the program, and then I had the highest selling store in the entire city of New York. Oh, okay, that's really cool. That is awesome. How does that connect to today? Like, let me see how these strengths show up today, because they do. Right? And even this gentleman has a phenomenal personality and a great sense of style. And in the beginning, he wore darker clothes. He'd wear his robe because we do telehealth. And I noticed one day he was wearing orange. One day he was wearing neon green. And that was him connecting to his previous identity. And that was really, really exciting. He's ready to share his story and to connect and inspire people. He's told his friends more and more about his journey, right? He's opening up. He's opening up to his sons in a way that's age appropriate and figuring out how to do that. And that's really important. And he has found new meaning. One thing I say to patients all the time, they probably get sick of it, is that life is too big to carry by yourself. And he's figuring that out, is that his meaning are his family and friends that have been there for him throughout this entire process. So things can be real hard, they can get really dark, and at the same time, he has the safety in the people in his life who love him and who haven't left him the whole time. And so this is my work with this gentleman helped me to understand the importance of helping patients develop a quest narrative post-lung transplant. So what does this look like in practice? Because this has been a little vague and theoretical. Pre-bolt therapy includes psychoeducation about mental health and trauma. It includes awareness of trauma and triggers, including psychoeducation about chaos narrative. Right? Like if you feel yourself spinning, if you feel like life is happening to you, tell me or tell someone. It's about identifying strengths and adaptability, right? Finding these threads that we can pull together for a quest narrative later, or trust in oneself. It's about habituating coping skills and reducing baseline, so that when someone wakes up after surgery and they're totally activated, they already have these things that they've tried that they can more readily put into place. And And it's really irritating because so many of the coping skills and self-help books out there talk about deep breathing, and that's a really inappropriate thing to do with most CF patients. And pre-Bolt therapy does include shifting to the quest narrative. So a lot of times I'll have a patient choose a book with a hero they like, and we'll read it together. And we'll talk about the hero and then use that post-transplant as a frame of reference. I do couples and family therapy pre and post-Bolt. Again, psychoeducation about mental health and trauma, even naming trauma for people who may not know it's a thing. Awareness of trauma and triggers, identifying attachment cycles, right? Helping people understand their relationship better so they can see where the relationship is shifting post-transplant and maybe where to step in and try and adjust. I always talk about building a container for emotions of transplant, right? You don't have to fix each other's feelings. We just need to find a box for you to trust that you can put it in together. And then providing caregiver support as well. I gotta go quick because I'm looking at the time. Post-Bolt therapy looks like reducing pressure. Again, it can be twice weekly sessions, and that's more common with our patients with intersecting identities. Or higher ACEs scores, adverse childhood experiences. Accepting dialectics, right? You can be extremely grateful and happy you're alive and really angry and depressed and sad. One doesn't cancel the other out. Again, habituating coping skills, bringing down baseline, recognizing pre-transplant self and post-transplant self, recognizing ways that you feel different or you've lost your sense of self, and either seeing if we can get them back or seeing if we need to do some grieving. And then shifting towards quest narrative. This is the hero's journey that I use with a lot of folks. I'm going to go through it quick because I'm over time. But this is something that's really important to me, and I apologize for just taking one more minute. Like I said, I never expected to have myself be part of transplant decisions. And it's a really important role that I play in patient advocacy because we have folks that maybe they're neurodivergent. And so when they're talking to medical staff, they don't really know how to explain themselves, or they don't really know how to process the nuances of the transplant journey. And it can be really helpful to say to staff, oh, this person has autism spectrum disorder, this person has ADHD, to help give them perspective of why the person's showing up that way, right? Also talking about family systems and how that impacts how folks show up, right? It's a very important role to play to give the patient's perspective during the committee decision-making. And it really can serve as a bridge between patients being listed or not listed with the insight that can be given. So I will conclude there because I'm over time.
Thank you so much, and we have time for a few questions. If anyone wants to put them in the chat or come up to the mic.
Can I ask one?
Yeah, of course.
This was so incredible. And I really wish I had someone like you in my transplant clinic. I'm getting a death glare that I don't have two amazing psychologists in my CF clinic, but in my transplant clinic, I'm dealing with a lot of these things all the time. And I wonder, a lot of us here maybe don't have as incredible of a background as you do in systems and being able to do all of that therapy. Is there a short way, and the answer may be no, for us to help shift someone out of, a lot of times I have the chaos in clinic where people are just in this chaotic spiral, and it would be so incredible to be able to gently push them into the quest narrative. Do you have some tips for how we can try to help as their team, even things maybe we're saying that we should stop saying, to push them into the quest narrative rather than the chaos spiral?
It's a great question. Very briefly, there's a lot to it, but one thing that stands out is giving patients as much choice as possible and also respecting when choices are hard, so not putting them in a position where they might freeze. But giving them as much agency as possible. And letting them know that I'm giving you this choice, right? Because I think a lot of times they get choices, but don't even realize they get choices because they're really impatient mode of I'm being told what to do. So choice makes a huge difference because it's the idea that they have some agency and can pick something and it can happen. And then, providing structure does really help, right? So some of this just takes time, but medical staff do provide really important structure for patients, right? It feels like chaos, and there's not chaos. There are these people who are there supporting them and helping them and who have been there before. It's not chaos for you because you've seen the transplant journey and you've seen people get to the other side, right? So even just like your dignity and like integrity in it of like the trust you have in the process can rub off on patients too.
I have a question. Oh, you have a question? Sure. Yeah, probably.
It goes very into the weeds of things, and it's not boiled down in the same way that this is. My hope in time is to figure out how to create a protocol that people could use in a way that is more efficient for folks to learn, because it's not written in the practical sense. It's more of this is what I saw in the interviews.
You should write that book.
Do you formally screen for ACEs or anyone on the team, or just as it comes up in sessions?
It's a really good question. Obviously, each therapist have different styles. Those who know me know that I steer clear of assessments and numbers to the best of my ability. And that's my own personal style. But I'm asking the questions in my head, and then with patients, just not formally this question, this question, this question. So I do run through it and take notes, but I'm not telling them I'm giving you a formal assessment.
Gotcha.
So.
All right. Thank you so much. Okay. And here you go. Thank you.
So from a lot of wonderful therapy talk to a little bit more sort of transplant and studies and more solid numbers. My name is Grant Turner again. I'm the Associate Director of our CF program, and I'm a transplant pulmonologist and the Fellowship Director for Transplant. And I have some funding from the CF and NIH, but nothing related to this talk. So I want to talk a little bit about lung transplant and get everyone to the same page on what we are talking about with who can be referred for lung transplant, what advanced lung disease means in cystic fibrosis, and that not everyone with advanced lung disease will be referred, but is a great opportunity to start discussing potentially psychosocial issues, and then specifically go through some of those psychosocial issues. We talk a lot in sessions about bacteria and FEV1s and things like that, but I wanted to go through more adherence, social support structures, and then alcohol and cannabis screening. So lung transplant, you hear this phrase every time, is a life-saving procedure for end-stage lung disease. The number of people getting a lung transplant every year is going up, but really exciting on both of these graphs, you can see the number of people getting a lung transplant for cystic fibrosis is going down with elexacaftor, tezacaftor, ivacaftor, and obviously with VTD as well. The transplant team is a wonderful multidisciplinary team, very, very similar to a cystic fibrosis team in a lot of ways. And there was a wonderful review that was just published in the New England Journal of Medicine by one of the physicians out of Penn that goes through all of the care members and has this wonderful graphic. The one thing I think that's missing from that graphic is the referring team. Selfishly, as a CF team, I feel like you are a part of that multidisciplinary team pre and post-transplant, definitely pre-transplant, but also post-transplant for people with cystic fibrosis. And it highlights the pre-transplant evaluation phase can involve a very long period of time where we're discussing risks and benefits, discussing the process, educating patients, going through their care system, and even considering things like palliative care. and whether we'll be able to help them recover. And there's lots and lots of other people on that care team, whether or not a patient and the caregivers actually see all of them, people like financial coordinators and people behind the scenes. The transplant social evaluation is really a massive endeavor for our social workers, our financial coordinators, and our team, and involves social, functional, and psychiatric components, and involves sort of learning a little bit about all of this in a very condensed way, and then being able to relay that in a committee meeting. It can be as simple as they are cleared to a very long discussion. So I think it's important to see all of the things that our social workers and our team are trying to find during that evaluation. So then moving a little bit into who we think needs a transplant versus reasons to not get a transplant. In a minute, I'll discuss reasons to get a transplant, but first want to turn to contraindications, reasons that we would not want to potentially transplant someone. There's a really wonderful position paper from the International Society for Heart and Lung Transplant back in 2021, and they go through absolute contraindications. So these are reasons we should not do a lung transplant in this person, risk factors with high or substantially increased risk, and risk factors. And it's really important that these risk factors don't add on top of each other. They actually multiply and stack in large ways. And so we want to make sure that we are recognizing all of them. And there are specific social ones, psychosocial concerns that I'll highlight in these long lists. So don't get overwhelmed by these crazy lists. The two out of absolute contraindications I want to point out are repeated episodes of non-adherence without evidence of improvement, especially in adults, basically, that peds, I'm not a pediatrician, so I will defer on any discussion there, but different developmental stages can impact adherence. And then active substance use, including tobacco, vaping, marijuana, smoking, and IV drugs. Risk factors with high or substantially increased risk, the two psychosocial components there are psychiatric, psychological, cognitive conditions that they think is going to, again, impact adherence without a sufficient support system and an unreliable support system or caregiving plan. And then lastly, under risk factors is edible marijuana use. And I'll talk a little bit about marijuana later on. Pivoting then back to cystic fibrosis, there is an entity called advanced lung disease, and this is a definition specifically laid out by the Cystic Fibrosis Foundation in a guideline statement that describes a group of patients that we should be watching very closely. This does not mean they need to be referred for transplant right away. If they've been referred for a transplant, they already fit into this group, but they're a group that we should be seeing more frequently, even if they're on modulators and overall doing well, because they have the potential to need a transplant soon. So the biggest component of that is having an FEV1 less than 40% when they're stable, not in an exacerbation. There are other specific components that are more related to functional components of respiratory failure, such as being in an ICU, needing oxygen at rest, having pulmonary hypertension. And these may be reasons that we may push them to meet a lung transplant team sooner than their FEV1 being ready for technically referral. The ALD group within the CF Foundation is being monitored very, very closely, and it's a growing population. So in 2019, they officially added an ALD form to the CF registry, and that allows us to more formally track these individuals, especially with recommendations regarding what they should be doing to monitor their disease. So you can see the numbers of individuals has been steadily increasing, both with recognition and with people completing the form in the registry. The mean age of individuals with ALD is 38, which is interesting in comparison to the general population in the CF registry with a mean age of 25. But otherwise, the demographics are basically the same: 9% Hispanic, 5% African American, and 89% of people in the ALD category are on a modulator compared to 86% in the registry in the 2023 report. But we'll see the 2024 report soon. So then, as I mentioned, not every ALD patient will need referral for transplant. Specific criteria for needing referral for transplant is FEV1 less than 30% in adults, and then less than 40% if they have one of those risk factors for decompensation soon from a functional component. or if they are sort of rapidly progressing, which we've all seen patients like that while there's still a higher number on their FEV1, they are going to need transplant referral and discussion sooner. In that advanced lung disease form, the CF Foundation had a lot of foresight to ask, why are people being referred for transplant? If they are, what was the outcome of it? And if they're not, why aren't they being even referred for transplant? Again, not all of this group necessarily needs to be referred, and so they may be in that perceived clinical stability top row. But there are important components here where a CF program is deciding not to send someone for transplant evaluation or discussion because of adherence issues in 8%, limited social support, substance misuse, smoking, and inadequate medical insurance. It's notable also that almost everything on this list can be related back to social determinants of health, that if you don't have a good support system, you probably won't be able to get nutritional supplements or make good meals, and so you're going to have poor nutritional status, or your mental health may be poor if you don't actually have a support system. You may get more exacerbations and more resistant bacteria. So all of these things could be related back to social determinants of health, but these are the most important ones that I highlight and we'll talk a little bit more about. So we're going to go through adherence issues, social support, cannabis, and alcohol. Right before that, though, sometimes people are wondering why lung transplant programs are able to make some of these decisions. Why are committees deciding to decline someone just because they don't have a support system, or just because they don't have insurance or have the ability to pay for their medications afterwards? And I think it's important that transplant in general is not the same as typical medical care, that we have to follow a very important set of ethical principles because there are not enough lungs from donors to meet the needs of recipients. And so we have to make sure that people that are going to get transplants are going to be able to take care of them well, and that we are really maximizing both utility, that we're adding years to their life, that we're giving them something that's going to make their life better, and that we're balancing justice, that we're not giving a transplant to someone that won't be able to pay for any of their medications or doesn't have anyone to support them, and that's taking a transplant away from someone else who may not get the opportunity to have a transplant. And then the absolute worst part of transplant in the United States is that we have outcomes that we have to follow. And if we take too many risks on individuals, that programs may close because we may not be meeting 1-year outcomes and be under review. And so there's always that risk tolerance that every program will have. So those are important things to think about when transplant programs may be making decisions. And the reason why there's lots of transplant programs to refer to see how different places may act differently. Adherence can be difficult to assess and difficult to define, but adherence really is compliance with a treatment plan that hopefully has been made in congruence together, discussing risks and benefits. But again, how do we measure this? There's so much potential bias in the term adherence and compliance that we bring to the table and that patients bring themselves, and isn't necessarily patient-centered. So it can be really difficult to assess in an objective way. Saying that, I'm now going to go through a study where they tried to make it objective and really created a cool tool that looked at adherence, both good, moderate, and suboptimal in 5 different domains, looking at health perception, how well they knew their medications, and how their diabetic control was. This program forces patients to do home spirometry and call it in. And so measuring how often they're doing their home spirometry and letting the program know whether or not they're answering the phone and answering messages, if they're getting good nutrition and exercise and what their BMI is, and then if their immunosuppression trough levels were within range, depending on how often that was being done. So then they were able to take that objective measure over several years, or what they defined as objective, and found what every individual person's adherence level was, and then we're able to look at above and below the median score. They found, and I didn't show, that the adherence over time decreases, which is not totally surprising, that people are really good in that first year after transplant, and then life starts to get in the way, and maybe you're not taking your meds or not getting your trough levels right on time, or missing phone calls because you're in a work meeting. So that adherence number does decrease. But for those that had below median scores of adherence in all of those domains in general, they were less likely to be alive at 5 years, less likely to have their grafts survive, and also more likely to have chronic rejection. And so they were able to then break it down into which of those subscores mattered the most. Huge shout out to our physical therapists and our dietitians, that nutrition and exercise were very critical components into adherence, that those who were very adherent in their BMI and exercise goals were more likely to survive longer. And then also trough levels, which makes sense. If you're taking your immunosuppression well, you're more likely to be able to live longer theoretically. They didn't see any difference in other post-transplant outcomes like rejection and infection. Moving over to social support, often programs require at least one caregiver for at least 3 months. Our program requires that you have to have a caregiver, primary caregiver who will be with you 24/7 for those first 3 months, and then a secondary caregiver who's available and can also do 3 months in case the primary caregiver has their own issues. Both of them have to be able to drive, and we need to be within 90 miles. And the secondary caregiver can be cobbled together with multiple people, but every program is different in that way. And this is critical, as we've heard from our caregiver representative, that post-transplant patients are going to need things like wound care, medication support and nagging, physical support, and mental support. This is an incredibly arduous journey, and caregivers are there to support people through it. Really interesting question is, does it matter who the caregiver is? And I didn't mention, but you're not allowed to hire a caregiver for our program, at least. So this study was very interesting, and I've heard people reference it before, but I was excited to find it and show it today, that it does matter, theoretically, who your caregiver is, depending on who you choose. So they looked retrospectively at 452 patients over 11 years and identified who the primary caregiver was, adjusted for other confounders that may have made their likelihood of survival lower, and found that if you have your adult child or sibling as your caregiver, you're less likely to survive to 5 years. There's a lot to digest in that. I don't have a sibling, but I have seen my partner fight with his sibling, and it is not fun. So I can imagine that over time could become a problem. And adult children are sort of in that sandwich where they may have their own children as well, and dealing with you as the patient needing that support. So I don't think we would ever turn someone down for having that, but it is notable that a caregiver may actually matter. On the flip side, caregivers also matter and are overwhelmed, and we have to consider caregiver burnout, especially in that post-transplant course that's less stable. The patient who stays in the hospital for 3 months and the caregiver was only signed up for 3 months, but now we're at 91 days after transplant, and that's when the 3 months really starts. That's can be really difficult. And there's some specific quotes here. You already heard from a wonderful caregiver, but making sure that we're highlighting the caregiver's needs at the same time, which can be difficult, especially as a physician, to really have potentially 2 patients sitting in front of me and sort of being the therapist for the caregiver at the same time and not getting in the middle of squabbles, especially between spouses. So then quickly moving over to alcohol and cannabis. Alcohol abuse and alcohol use disorder is very common in solid organ transplant candidates, very high in alcohol-related liver disease, but as much of a third of lung transplant candidates may have an alcohol use disorder at the time that we're evaluating them. And it can be really difficult to identify who those patients are that are having alcohol use problems. It's a critical component of a transplant eval because their post-transplant course will be very dependent on them not abusing alcohol. And they have specific reasons why they may not report their alcohol use to you, that there may be memory bias, they may be under-reporting, and definitely a social desirability bias and sort of variability in how the questions are asked. So to help with that, there are specific biomarkers. You can draw a blood alcohol level when they come to meet you at the time of evaluation. But again, if they're actively drinking to come to a transplant clinic appointment, that is a whole other problem. But it's definitely happened, but it is concerning. The more important helpful test that we've definitely started to use is something called the PEth test, or phosphatidylethanol. I like to describe it as the hemoglobin A1C for alcohol use, that over time, chronic alcohol use incorporates this, you can see in the diagram, ethanol becomes phosphatidylethanol and incorporates into red blood cells. And so you can measure, I always warn my patients when I'm asking them in that first visit in transplant clinic, how much are you drinking? And then I say, we're going to be checking today what your level of it is over the last couple months. Do you want to change your answer? And if the number is high, then we're going to discuss what we're going to do differently. So what a center may do is very variable. If someone comes to us with a problematic history, then we require 6 months of abstinence. And we specifically are getting those PEth tests on everyone whenever we decide to do an evaluation. If it's very positive, which is like over 100, meaning that they're a heavy chronic drinker, that we require complete abstinence again with 6 months of negative monthly tests to prove that. And then usually have them also go to AA meetings or meet with a specific addiction counselor or a part of our addiction team to discuss potential treatments, because there are wonderful treatments to help with alcohol use disorder. If it's positive and low level, we recommend abstinence as long as there are no problematic behaviors, and our psychiatrist and our social worker and the committee all agree. And then post-transplant, we ask them to avoid alcohol completely for at least 6 months. And then if they didn't have a problematic history, we allow some minimal alcohol. But again, worrying about drug interactions and liver health. So lastly, just wanted to quickly discuss cannabis. When we had our planning meeting, the cannabis came up, and it's definitely something that can be very variable depending on where you are in the country and sort of your own personal thoughts on it. The usage of it causes a neuropsychiatric side effect, which is the desired effect, but it also causes neuropsychiatric side effects that it can cause memory problems, and other sort of long-term damage. And it's specifically worrisome in lung transplant or in cystic fibrosis is that it can cause hyperemesis syndrome, especially with increased use over time, and that it can cause aspergillus infections. And so from a CF standpoint, we do a little bit of harm reduction if we can't get someone to stop smoking, to at least microwave their weed for a little bit before using it to try to kill off any fungal spores. After transplant, and before transplant, they cannot use any smoking, actual smoking or vaping, but that's sort of our harm reduction. And then cannabis has a direct drug interaction with a lot of our transplant medications, both immunosuppression, antifungal medications, and then some of the prophylaxis we use afterwards. And so it is very important to have lots of discussions about cannabis use. Every center will have a varying policy that may be from complete abstinence to only depending on how they're using it. Almost every program will say if you are going to use it, it has to be edible only. This was a wonderful survey of solid organ transplant centers that they broke it down by if it was legal in the state that your transplant center is in. And based on if it was legal or illegal, you had a policy or didn't have a policy. And basically everywhere that it was legal for medical or recreational use allowed people to be actively using some form of cannabis. But I think it's really important that you distinguish if it's medical, recreational, or an actual use disorder. And even more so important going into transplant is that they have not only better coping strategies, but also medication therapy if they're using it for depression or anxiety, because they won't be able to have it during their transplant hospitalization when I'm giving them 3,000 milligrams of prednisone. That will make anyone anxious. So we need to make sure that their depression, anxiety is much better controlled than using cannabis going into transplant. So overall, the evaluation for a lung transplant, multidisciplinary, similar to a CF team, and really requires a thorough psychosocial evaluation. There can be absolute contraindications, but we have very clear advanced lung disease criteria from the CF Foundation and very clear referral guidelines that I think should help push CF programs to sending patients to us so that we can discuss some of these absolute contraindications and try to make them go away if possible. Adherence has definite significant effects on short and long-term outcomes. Depending who your caregiver is, you may do well or not after transplant. So having a caregiver plan that's great going into a transplant is helpful. And then specifically alcohol and cannabis use are going to require a lot of discussion and determining if there's use or abuse. The key takeaway, hopefully you take from this, is that as a transplant program, we want to see people earlier so that we can discuss these things before the person has been using marijuana, recreationally and now is on ECMO, and we can't decide whether or not they should be transferred to our center. And so meeting them early and making sure that we can clear out those absolute contraindications is incredibly helpful for us and hopefully the patient and your team. That's it. Thanks. We're only 3 minutes over. That's pretty
That's
good.
great. Anybody have any questions? Thank you, Dr. Turner. Yes, of course. Oh, you can ask, yes.
How do you approach the caregivers drinking alcohol and smoking?
That's a really great question. I don't think that often at least from a physician standpoint, I end up talking to them very much about that. It's usually the social worker who brings that concern to us. And we usually have to have those discussions then after we find out that they're actively drinking or smoking in a disorderly way, and either say you can't be the caregiver if you continue to use these substances in that way. If they're actively smoking, we will sometimes say they need to remove themselves from that situation if they want to continue to be a candidate, especially if their lung disease is smoking related, because that then increases their likelihood of going back to smoking afterwards. So it's complicated, definitely a case by case scenario, but would want to have a caregiver that's more stable, definitely.
Hi, thank you for the great talk. In regards to the adherence paper that you had referenced, is that adherence post-transplant?
Yes.
Do you find, I know a lot of lung transplant programs utilize a behavioral contract. I don't know if your center does that, but is that very impactful on adherence?
No.
Is that
We specifically don't use a behavioral contract like that. I think maybe I haven't examined the literature, but I know a lot of opiate addiction counselors or addiction physicians will use opiate contracts and behavioral contracts, and those may be more meaningful. But in our experience, even caregiver contracts aren't binding in any way. And so if someone has already gone through with the transplant, we have nothing that we can hold them to afterwards. We can tell them our expectations, we can counsel them on everything that we're going to ask of them, but having them sign a piece of paper, at least how our program feels and I feel, it doesn't necessarily mean anything to them afterwards, because I'm not going to bring it to them and be like, you signed this piece of paper, you must go take your tacrolimus.
I'm just wondering because I feel like I'm an adult CF program provider, and I feel like sometimes when we see patients who should be referred, I feel like we are the gatekeepers in some way, because it could be an extremely non-adherent patient, have a lot of social, legal concerns, and I don't know like how modifiable these things are, but I also don't want to be the person to say you are meeting, like not being a transplant program provider. Like I don't want to be have that responsibility fall on me, but also I don't want to taint the impression that patient may end up giving to the transplant program. So it's kind of like a balance. How much can I modify for a patient to optimize things and then do that formal referral? What are your thoughts?
I think if someone meets criteria for referral, I would have them come and talk to us. And having that discussion may be enough for them to start realizing they need to start making some
Right.
changes. And hearing it from you is incredibly impactful. You have this long-term relationship with them, but sometimes coming and meeting us is the push that they need to actually make those changes. I'll give a very brief example of that. A patient I met, not CF related, but was 70, was already on oxygen, very clearly had horrible acid reflux, and him and his wife had a bottle of wine every night. That was their thing, that they traveled, they loved wine. When I met him, I said, your acid reflux is making your lungs worse. You have to stop drinking. And if you ever want to transplant, you have to stop drinking. By the time I met him saw him 3 months later, he had given away his entire wine cellar. All of his testing was negative. He was very motivated. And so that's an extreme example, but I think often meeting us as a transplant team, we don't have to have that long-term relationship ongoing with them. And so we can say, you're not going to get a transplant if you continue doing this. And that may be your only chance of extending your life. And so XYZ has to change in a way that you're not able to, because you have to take care of them regardless of transplant or not.
Thank
So
you.
hopefully that can be
Yeah, no,
helpful.
thank you. I agree. Thank you so much.
Yeah.
Hi. My question to you is, how much education do you like patients to have before they're referred from their CF center? Or is it okay to just refer someone and you guys do the majority of the education about what transplant is? Like, what's preferable?
Yeah, that's a great question. There is some resources that just got released from the Partnership Enhancement Program about lung transplant referral. I'm looking right behind you. Abigail is the one that runs that. And we'll hopefully be putting together some more helpful materials for the CF team on how to educate someone going into the referral. But also, I would say it's not your requirement, your responsibility to give all of that education, because things that regarding transplant are changing. And so someone who only does CF and hasn't seen the active transplant evaluation or post period may not have all of the up-to-date information. And so it can be helpful sometimes to not give like, this is how long you'll survive afterwards, because then people come to us with very old statistics and don't really fully understand how things have changed over the years or what the medications are like. So I think from a CF team, explaining why you think the referral is important and why you think they should meet the team. And you can give a little bit of background, but I would not make it an extensive educational component, I guess.
Great, thank you. One follow-up question actually that isn't relevant. Sorry, do I have time?
Okay. No, you're fine.
I didn't see any vaccine requirements. Is that, sorry.
Not sure in 2025 if I can answer that, but most centers will say that you need to meet the CDC required vaccination list. I don't know what that will look like moving forward if the CDC doesn't have vaccine recommendations, but every program will be a little bit different in that way. Yeah.
One last thing.
Yeah.
Just a plug, I'm a transplant social worker who works with our CF center. Just a plug, reach out to the transplant social worker. There's lots of resources. There's oftentimes peer support programs, support groups. We'd rather you come to us. We can provide all of the education as much as we provide beforehand. So just a plug, don't be scared to refer early. It's better that way.
Thank you so much. Okay.
Thank you. All right. I'm the last speaker and mine may be a little downer here, so I hope you don't find that, but it is a case and it doesn't end well anyway. So it's one pediatric patient perspective from a referral center. And I don't know if I said before, but I'm at West Virginia University. So it's an 11-year-old who received a bilateral lung transplant. And this is a brief history, but you wonder, how did an 11-year-old get to needing a lung transplant? Well, the day she was diagnosed in the PICU, because this is pre-newborn screening, she had RSV, she was going into respiratory failure, and then we came to find out that she had severe tracheomalacia and could not come off the ventilator and was trached and vented for 3 years of her life. had 2 chronic infections, mucoid pseudomonas and MRSA, that never went away. And that really escalated her lung disease, although she did get decannulated when she was 3. But as most babies and children are who are chronically intubated, she had great oral aversion. She never really had good nutrition, and she was short stature. So she was not on any supplemental oxygen and was doing well, even though she was small. And then she had a severe pulmonary exacerbation with viral illness at age 8, and that shifted things that she then required oxygen BiPAP and then was on the trajectory toward respiratory failure. And so she got referred for lung transplant, and at age 11 was when her surgery was. Now, a little social history. She was the oldest of 3. Her 2 younger siblings do not have CF. The mother was 13 years old when she had this young lady, and the parents weren't married, and I remember all the chaos, but then finally they got married, and the dad was 13 years older. And through the course, we knew a whole lot. They split apart, they got back together, they split apart, but they finally decided that in order to take care of her and the 2 other siblings, they stayed married. And they did have 4 grandparents who all lived local to them. Sometimes they were helpful, sometimes they were not, but they were very involved with the family. The other thing that was very challenging was this mother she was young. And she had a child on a ventilator for the first 3 years of her child's life. So at 16, her child gets decannulated. That's pretty amazing. This young lady grew up very quickly, and I think she was a child with her child through the whole process, because she really lost her childhood. I mean, she had a chronically ill child, but she went to 3 different centers, and she kind of ping-ponged all around, and she'd get mad at people. But then when our patient was 8, she chose us. She came back to us as her primary center. She still threatened to leave a lot, but we were her center. And I was the one who called when her 2 other children were born and did not have, by newborn screening, have CF. So even when she was mad at me over something, we're still there. So one of the questions is, what should be in the involvement of the referral team? And there is this guideline, and I looked, there really isn't anything updated since this article in Chest in 2017, but and the CF Foundation has this advanced, lung disease. So that's all there. And I think I'm pretty good at recognizing when the decline is coming, although I'm a pediatrician, so now I don't really have I have 1 maybe I'm worried about. But there really is, if you're close by and you're the same center director, but maybe your patients come from elsewhere, but it's challenging when there's a distance. And how do you, and this is the theme of my talk, I really encourage that there be more of a connection pre and post-transplant. So pre-transplant, we had lots of conversations about just getting our patients to go and be evaluated. I feel like it's this broken record sometimes. But then once they've been, do they get listed? And that's another, it goes on. And then you have a child who's 8, 9, 10, and believe me, she looked much younger. And through her whole life, she looked younger than she was. So you forget that you have a preteen who is really wanting to be a preteen, and yet she looked like she was 5 or 6 years old. And then later on, she was older teen, and she looked still like she was maybe 10. So, and I don't know that I ever really knew how much the parents together were prepared for this. It's really challenging. They lived in rural West Virginia, and we rarely had both parents together. And then we have a young, what seemingly, though still immature patient, and then hearing the talk, oh my goodness, how much trauma she had. She had the oral aversion, but she had a trach, and then she didn't go to school, or she was allowed, then she wasn't allowed to go to school. And then the theme for her was that she just wanted to be normal. She wanted to be with her siblings. She wanted to go to school. She wanted to play in the backyard. And there was a lot of obstacles in her way. And then at the time, we didn't have a mental health coordinator And I don't really know what the family received on really pre-transplant counseling and I think they needed family counseling. And like I said, this is a mother who was just a teenager herself, very, very capable and very competent, but still challenging. And so, the mother shared that she had been told that she was trading one disease for another. We heard that earlier from the patient, but she said they should have just told me they were trading one hell for another hell. And that's very impactful. It's like, wow. She just said, I was never really fully prepared for what this would look like. So her post-transplant journey, she had 1 or 2 really good years. She did develop CF-related diabetes. Then she developed chronic rejection. She had renal insufficiency, and she developed chronic parvo. For those of you who don't know, people who are immunosuppressed can't clear parvovirus, and it suppresses the bone marrow to make blood. Basically, you're chronically anemic, so she needed immunoglobulin to help her kind of clear her parvo for a little while, and then that would fade off, and she got transfusions. And that was a big, long issue. But her nutrition was poor. She never really ate well, and she had gastroparesis and didn't tolerate feeds. I'm really condensing the whole way. But then she got a little older, and then she had a couple brief episodes where she had acute renal insufficiency and had a dialysis catheter, and she hated it. And she wanted it out, so then eventually it was pulled out. And she had at least 1 or 2 where she was intubated, and then because of her past tracheostomy, she had a lot of trouble with her airway, and there was talk about putting in a new tracheostomy to help her, and she didn't want it. But the parents wanted it, and then she'd get in the ICU and get reintubated again because of respiratory failure, and yeah, it was a lot. And then trouble with line access. You have a teenager who's had multiple PICC lines, multiple ports, and then dialysis catheter, and you run out of sites. So here we are then, and she's 17. And so, and she would repeatedly just say, I just want to go home. So there was a constant disagreement between her mother. Her mother was the main one we saw. The mother I remember her saying, or she said to our team, we're going to get out of this if there's another transplant. And she said, I don't want another transplant. And the mother said, don't talk like that. And the patient said, Mom, there are going to be some things that I'm going to miss. And that kind of sums up, how the patient felt. So I think then it's the post-transplant. We ended up caring for this young lady the majority of the time. But the parents then would say, well, we need to hear what our transplant center would have. And we got levels, and we'd phone in the levels, and there was always waiting hours, sometimes a day to get a phone call back. And it's challenging. And then frequent hospitalization, she'd be by herself because she lived almost 3 hours from our center, another hour and a half or 2 to the transplant center. And you talk about answering phone calls. No, they didn't answer phone calls. It was very, very challenging. So, rural West Virginia, it's beautiful. And this time of year, it's really beautiful. Not live near a highway, only maybe the very end getting to Morgantown. But, and then when it's like this, what do? But the other challenge that we had was that they had very poor to no broadband or internet, and their cell phones didn't work. So that might have been part of why we didn't hear from them. And of course, now we know just recently the last DSL is gone. But this is West Virginia, and this is a challenge that we really have with patients. So home health would do home IVs. Then after a while, they're like, we quit. We won't service them because they won't answer. They're not home. They won't answer our phone calls. Then it was really getting into the dialysis issue. The patient refused a catheter. Did she need to, what did she need? If she had labs, they didn't go get them drawn. And I already said that we couldn't reach them or by our EMR, my chart on Epic. or then they wouldn't come because they were afraid they'd be admitted. And that happens with our CF patients anyway, but then here you have a post-transplant. So it then woven in here you started out with an 11-year-old, and now you have an older teenager who in many ways should have autonomy over decisions, and yet there was not in agreement with her family about dialysis at trach being listed for a second transplant. But I'll tell you the other trouble is there were a lot of cooks in the pot. So I'll just tell you, she was in our PICU a lot of times, and so they got to know her, but they had definite opinions because they're PICU people, and and then we had hospitalists on the floor. Sorry. Then we had the nurses were great and they would have relationships, but they'd come and express their concerns. Like you said, the behavior isn't always we learn it. We learn it from the nurses or the social workers. And then we had a transplant nephrologist and our supportive palliative care. We had our own nephrologist, our team, transplant, trying to reach, we didn't always get the same person. And then mom fired our nephrologist, but then she was a very nice person and gracious, and then would say, I can't not help with her. And we tell the family, you fired our nephrologist, she's got kidney issues, you need to go. No, they didn't want to go and be transferred to the transplant center. So it's really, really challenging. So, how can we better prepare for the hope of a double lung transplant and then the reality of end of life? I will say I have spent a lot of time over the years. I obviously, been around a little while, and I used to take care of adults, and I've had adults, my patients, be transplanted. And so you have a lot of conversations about the hope and the reality and where are you. And then usually we're out of the post-transplant. Most of them, and the adults, I would see them socially, or we would say, oh, you need PFTs, you can come, and I'd meet them in clinic and say hello, or you need labs. But most of the time, if it's going well, we're not involved. But I think it's when it's not going well, that's where we were. And so some lessons that I will say we learned. Well, there are bonds that we share and they're strong, and I won't turn away from any patient no matter where you are. And I tell them that, no matter the journey of where we are, and I'm not afraid to talk about issues and we have to be there. And so we embrace this patient as our own. As a team, we spent a lot of time talking about her, and one caregiver would see her and hear the conversation with the family, and then you had to let everyone else know because maybe it was going to be you the next time seeing her. But and using our supportive care people. So how do we improve our team with navigating this? And so for some people, they we're naturally people who feel more comfortable with some conversations and others not, or you may, if you get yelled at by the mother, you don't really want to walk back in the room the next time. It's like being hit over the head. You're not going to walk into a situation. So it was navigating all of that. But it is about communication and support of our team members and communication as much as we can with the transplant center. I think it could really be improved. And now I think about it and say, we never suggested, Teams or Zoom, but maybe that really could be helpful when there really is a patient who you're trying to co-manage, and really be helpful to say, yeah, get everybody on the screen together and let's talk about this. Maybe with the family and the patient, do one in the room with the family. I think it's really, really important. One thing that maybe you all haven't thought about, but I've had another patient who was my patient, got referred for transplant when he was 17 or 18, got transplanted at age 21. And in the adult transplant center were peds. Then he became 22, 23. Our adult center did not know him. And so it was still back to me for him. So that's an issue. When you're a kid, when you go, but then we were encountering with this young lady. She was a kid. She went to a pediatric center. Now she's becoming an adult. Wasn't quite ready, but we have to really face those. And I don't know how many teenagers you get who maybe are coming from a pediatric place, but going to the adult center. Maybe not. Well, CF, good. We're not needing it, which is, you showed this, and I'm showing this. The number of transplants have gone down in cystic fibrosis, and the pediatric ones are a very small percentage of these. Sorry, I don't know exactly how many, but we still have to do a good job. We have to do a very good job, even if the numbers are lower. So maybe there needs to be an update on that comprehensive care, but really with an emphasis on coordination of care, because these are the issues, that I think probably other people have said, and it's never too late to learn. So, I learned a lot from this, patient. Thankfully, I don't have anybody on a lung transplant list or really headed there now in our pediatric center, which we're very glad for. But I used to. So, that dynamic has shifted, but I think we have to be realistic. There still may be some pediatric patients who are going to need to have lung transplant. I talked about video, but then how do you pay? How do you bill that? Well, I don't know how to answer that one if you both are on a call, but we do a lot. I'm an infectious disease specialist. I give away a lot of my services, and, it's okay. It's not about the billing. It's about the patient care. And then looking for resources, helping your team, especially when it's about palliative care. We heard these excellent talks, and thank you. We now do have a mental health coordinator, and I think that that's key for everyone in cystic fibrosis, to have, mental health, cystic fibrosis. What'd you call it? You're the
CF therapist.
The CF therapist. There we go. So I think that sometimes it takes one patient experience to push for change, which I really believe. And I'll take questions. I didn't go over. And just a little plug. I don't know if you know this. The newest United States National Park is in West Virginia, New River Gorge. So really beautiful place to come. So thank you.
Question.
Sure.
I haven't been in CF care forever. I'm in year 5, but I'm about to experience a very new phenomenon where we take over the CF care, and I take over the transplant care for someone who was transplanted at age 14, 15.
Right.
What recommendations do you have for me? Because I'm a little worried.
Well, we hear a lot about trust, and I think that I know this when I meet a new patient who's come from another center. They know right away when you don't know what you're talking about, and they know right away when you do know. So you go in prepared, knowing what their history was, not asking, when did you get your transplant? Hopefully you know all that, right? And you know their complications, so then you can go in but I think it's establishing trust. And I think that's probably the biggest key. And I'm sure you're good at that.
We did do a handoff visit we have a quarterly visit with our sort of pediatric, non-UCLA center that refers a lot of patients to us. But I'm wondering if I should have the transplant program talk to me a little bit more too, and maybe include the transplant coordinator.
Well, I
sitting in the
know
audience.
that's what we do in our, I like to think of it as a transfer, because it's getting them ready for the transition, but we have the adult provider come to our clinic, and then we go to their clinic. So that shows to them that you are communicating. And don't be offended if your patient then asks, or maybe even calls their pediatric and asks. So when I first came to WVU, I inherited, all these patients, and it was almost 10 years that I'd learn a family would come and see me, and they were very happy to see me, and, for their routine CF care. And then I would learn from the previous center director that they had called him in Philadelphia, and he said, I just changed their enzyme or their vitamins a little bit or whatever for 10 years. And it took, so it takes a while. So not to be offended by that if you hear and that they called their previous person and you'd be like, good, how are they doing? Do they want to talk to me? If they want, but letting them know that you don't be offended by that.
Great.
Yeah.
This question is for you, or really any of you up here. I'm curious how you all balance talking about transplant and like all of the bad things that can happen and also the hope. Because I think we saw in the caregiver story that she really talked about this idea of like, she wished that they hadn't sort of framed it as like, you're trading a bad thing for a bad thing. And yesterday there was a community speaker who had CF who had a transplant, and he talked about how he now is living this life that no one told him he could hope for. And so I think both of them are kind of like speaking to this idea that like, yes, in the medical world, we want to come in really hot with all of the possible negative outcomes. But I'm just curious, like how any of you think about talking about all of the possibilities that this decision can hold for them.
Yeah, see, my family, the mom felt that she didn't hear it or wasn't told, but their journey went down, and it might have been very different if their journey had been that she hadn't gone into chronic rejection. Do you want to comment?
I have a comment. I have a patient I'm doing therapy with who is listed up for a liver transplant. And what I really encouraged her to do was reach out with CF Peer Connect to other people with CF that have gone through a liver transplant. So she can kind of forge that path for herself. She saw the ones that the quality of life is worse than before and the ones that are a lot better. So she's able to kind of determine that for herself by seeing just different patient narratives. So I thought that was really helpful for her specifically.
I think that can be really helpful too, to hear from other people, because I can say all of these wonderful things and then lots of negative things. And what people will walk out of that room with is probably only hearing the negative things. Like I can say, you won't be on oxygen anymore. You're hopefully not going to cough. We, hope to give you years and years and years of life back. But chronic rejection, horrible meds, we're going to be seeing each other nonstop and you have to hear all my jokes, like all these negative things. And they just remember the negative for a lot of it. And so we force all of our patients to go to the support group that has pre and post transplant patients on it. So they hear the good, the bad, the ugly. And then hopefully we will have better education as well about what is good and bad that people can digest in their own time frame. Kathy Ramos, University of Washington, has a NIH-funded trial that's creating a take-on transplant website and seeing how that, for people who may eventually need transplant, gets them ready for it. I don't think there'll be a big presentation about it at all this year, but hopefully next year, and then it'll be available for everyone. But we have to educate in waves, hopefully. And that's another reason why early referral is so important, so that they're not meeting me like when they're on ECMO and all I'm saying is like, we really need to get you through this and I want to give you life back.
Right.
There was a question in the front earlier. I don't know if it was addressed.
It was actually a similar question. I heard that multiple times. Like, I'm guilty of saying that many, many times in clinics. We're trading one set of problems for another, but like being aware of the language and what you guys recommend saying instead when you're talking to patients.
Going back to the metaphor that I said I use about life being too big to carry by yourself, I talk to patients very realistically about we're not going to be able to lighten the load that you're carrying. What we're going to do is figure out how you carry it. And the longer you go on, the more able you are to recognize how to carry it, right? So in the beginning, it may be that your caregivers are carrying the brunt of it. But in time, once you learn yourself post-transplant, you figure out how to carry it more and more. And that includes in the beginning, pre-transplant, identifying strengths, identifying different themes of their values, things that they're going to bring into it that show that they're adaptive and can get through hard things.
So I have a question. I work in a peds CF clinic, and this is my second kid who's been referred for transplant, so I feel like I'm still in the baby stages of figuring out what in the heck's going on. I was curious how much the transplant teams work with palliative care teams, because the second kid that we just referred is in a really bad shape, and there's so many risk factors that he may not get listed, and it's like, this could go either way. And I was just curious how much interconnection, discussion. I feel like right now, there are too many cooks in the kitchen and nobody's driving the boat. And it's so uncomfortable for me as I'm watching. It's like watching the car crash and going, oh God, who's driving this?
So I'll tell you, I've been in many scenarios where the person comes in great respiratory failure, and the family says, well, what about lung transplant? And so what I've learned is I call the transplant center and I say, okay, I have this. Now, sometimes if they're already connected, we're going to send them there. That's what happens. And maybe they haven't been listed, but so you need to find out from that center, well, what if he needs to be intubated? You know, or do we intubate him and send him to you, or do you not want him, or are you ready? Or, you know, that should be clarified from them. But the other scenario is what I've had is where they have never gone to be evaluated. And now here we are, and we call, and then we get the answer no. So then, yeah, we use palliative care, and we're on that end. But I think your referral center deserves to help you to say, where are you in that meeting? I don't know, when the meeting happens, or do you defer from the meeting and say, I mean, I don't know. I just think that should be clearer for you, because when you want to be prepared for that crisis when it happens.
Do you mean the committee meeting, or?
Yeah, and if they're not listed yet, then do you want the phone call, hey, do you want the patient, or do you say no?
Yeah, if they're already evaluated and accepted, then I'm usually in direct contact with the referring. And I also tell the patient and their family, like, never let someone say, like, there are no options or anything like that. Like, you need to call me. This isn't a, like, someone called you. It's you call me directly. I need to hear from you. And then going back to, like, the original question, we're not good enough probably at getting palliative involved, that there probably should be more of it. I think some transplant teams don't love getting them involved because then patients may not want to go through with it when they hear the good and the bad, for better, for worse. I think that we should be getting more palliative care involvement, definitely, that it would be helpful for them to hear all of their options.
Ours have tried to rebrand it as being called supportive care. I don't know, yours too, yeah, so that it's maybe not, because you hear palliative and then they think hospice, but to reframe it that I think they could be helpful in many, many times in the whole journey of their life. So if you call them supportive care and you get them involved, I'm a big advocate for that. Yeah.
Yeah, hi, Abby Thaxton with the CF Foundation. Thank you all so much for such a powerful talk. I'll just quickly echo the palliative care comments. There are published guidelines for CF-specific palliative care, and they really underscore the sentiment she just shared, that it's beneficial along the continuum of care, not the myth of just end-of-life care. And then a few other resources I wanted to highlight, which were sort of sprinkled in here. The CF Foundation does have a position paper on CF-specific post-transplant shared care, in addition to a CF post-transplant shared care checklist for care teams. These are really tangible, helpful tools that you could use to help sort of convene the village that needs to collaborate and work together between the CF Care Center and the transplant team. And I know we're at time, so our team is here if you have any other questions about transplant or advanced lung disease specific resources. And thank you all again. Great talk.
Thanks.
Thank you.
Thank you.